Imagine someone intentionally designing, like a biological booby trap, inside a standard medical pill. A pill that, if you take it exactly as prescribed, safely delivers a life-saving medication. But if you try to crush it up and, inject it into your veins, this hidden chemical mechanism violently snaps shut.
Yeah, and it instantly sends you into severe physical withdrawal. I mean, it sounds like something out of a spy novel, right?
Totally.
Yeah.
But pharmaceutical companies actually use this exact mechanism every single day.
They do. And the wild part is that the trap doesn't rely on nanotechnology or like hidden microchips. It relies entirely on a quirk of your own digestive plumbing.
Which brings us to the mission for this deep dive.
Yeah.
We are unraveling a massive stack of medical and pharmacology notes today to decode a concept called first-pass metabolism, because it answers a question that affects every single one of you listening. Like, why can the exact same dose of a drug be totally life-saving or completely hopelessly useless, depending entirely on how it enters your body?
Exactly. The route of administration, whether you swallow a tablet or stick on a transdermal patch or get an injection, it is never just a matter of convenience. It's actually one of the most high-stakes mathematical decisions in clinical medicine.
Okay, let's unpack this plumbing, because looking through these anatomical diagrams in the notes, it's pretty clear the human body just wasn't designed with modern pharmaceuticals in mind.
No, definitely not.
There's this formal metric I keep seeing here called bioavailability, represented by the letter F. And the definition given is that it's the fraction of a drug that actually reaches your systemic circulation completely intact. So by definition, an intravenous injection, an IV, is 100% bioavailable. You push the plunger, the drug goes straight into the main bloodstream.
Yeah, and it travels to the brain or the heart immediately. That pathway is essentially a straight shot, but an oral pill takes a much more harrowing journey.
Right, because you swallow it, it goes to the stomach.
Down into the stomach and intestines, exactly, where it breaks apart and gets absorbed into the blood vessels lining your gut. But here is where the anatomy takes a really strange turn. The blood draining from your digestive organs does not go directly back to your heart to be pumped around the rest of your body.
Which is what you would intuitively expect, right? Blood goes out, picks up nutrients, and goes back to the heart.
You'd think so.
Wow.
But instead, all of those blood vessels from the stomach and intestines, they funnel together into this massive biological highway called the hepatic portal vein. And that vein delivers all that freshly absorbed, nutrient-rich blood directly into your liver.
The body's primary chemical processing plant.
Exactly. And to understand the why behind this detour, we have to look at our evolutionary history. The liver is incredibly dense with metabolizing enzymes, specifically the cytochrome P450 family. It evolved over millions of years as a mandatory detoxification checkpoint for literally everything we consume.
So the liver has no concept of modern medicine.
None at all. To those enzymes, a helpful synthesized blood pressure molecule is completely indistinguishable from, say, a deadly alkaloid toxin you just ingested from a poisonous berry. Its sole biological mandate is to neutralize unknown substances on this first pass through its tissue before they can reach your brain or heart.
Reading this, I just kept picturing the liver as a highly zealous, extremely suspicious airport customs agent.
That is a great way to think about it.
Right. Like if you fly domestically, meaning you bypass the digestive tract entirely by getting an IV, you never even see the customs agent. You arrive at your destination with 100% of your luggage. But if you fly internationally, meaning you swallow a pill, you are forced to land at the international terminal and pass through customs.
And that agent just ruthlessly goes through your bags.
Yes, confiscating massive amounts of your luggage before letting you into the country. You might arrive with 90% of your items, or you might arrive with 3%.
And it all depends on how strict those enzymes are with that specific chemical structure. The liver is essentially destroying the active drug before it can ever do its job. Though looking at the modern biopharmaceutics notes, the definition of this checkpoint has actually expanded significantly in recent years. The customs agent isn't solely sitting in the liver anymore.
I noticed that. The older science seemed hyper-focused on the hepatic pass, but the modern literature recognizes 4 distinct sites of pre-systemic elimination. It's basically a gauntlet.
It really is.
Right off the bat, there's the gut lumen itself. The hollow space inside your stomach and intestines is filled with corrosive stomach acid, harsh digestive enzymes, and massive colonies of gut bacteria. They can physically dismantle a fragile drug molecule before it even touches the gut wall.
Which is precisely why we cannot give insulin as an oral pill. The stomach acid would just shred the protein structure into useless fragments.
Oh, that makes total sense. So it has to survive the acid first.
Yep. Then, even if the drug survives the lumen, it hits the intestinal wall. The actual physical cells lining your small intestine contain their own metabolizing enzymes, like CYP3A4, which actively break drugs down right there.
And the notes mention those cells even have microscopic pumps that will grab an intact drug molecule and forcefully throw it back out into the gut lumen.
Yeah, it's wild. So it has to survive the acid, survive the intestinal wall enzymes, and then it takes the portal vein to face that massive hepatic liver pass we just talked about.
Wow. Oh, and for certain specific routes of administration, there's a fourth site too, right? A pulmonary or lung first pass.
Yeah, the blood has to travel through the massive surface area of the lungs before hitting the systemic arterial circulation. And lung tissue can extract highly fat-soluble drugs right out of the blood.
This entire system just seems incredibly hostile to medicine, which really makes me wonder about the history here. Since the body's checkpoint is so aggressive, how did doctors first figure out this invisible confiscation was even happening?
Well, looking at the historical timeline, this wasn't discovered under a microscope in a pristine lab. It was discovered through incredibly frustrating, terrifying failures at the patient's bedside.
Right, because you have to put yourself in the shoes of a cardiologist in the 1960s. It must have been a deeply confusing time.
Oh, absolutely. Clinicians kept hitting this invisible wall where they would administer a drug via IV, and it would work beautifully to stabilize a patient. But when they tried to transition that same patient to an oral pill version so they could go home,
The drug did absolutely nothing. Even when they gave massive oral doses, the patient's symptoms would just return. The chemicals seemed to just vanish into the ether.
exactly. And there are two famous case studies from that era highlighted here that force the medical community to formally recognize this.
The first one involves a drug called lidocaine. In 1971, a researcher named R.N. Boyes was trying to use oral lidocaine to treat severe heart arrhythmias. They set up the trials, gave the pills, and the drug proved completely, dangerously useless.
Because the arrhythmias wouldn't stop. The liver's extraction ratio for lidocaine is just incredibly high. The hepatic checkpoint was stripping almost every single molecule of the drug out of the portal vein before it could even reach the heart.
Which totally explains why today you never see a lidocaine pill. If you need lidocaine, they give it to you through an IV in the ER, or the dentist injects it directly into your gums, or you rub it on your skin. You bypass the gut entirely.
Exactly. And the second story from the notes is about propranolol, which was one of the earliest beta blockers used to slow down the heart rate.
Right. In 1975, a clinical pharmacologist named David Shand finally demonstrated that if you actually wanted to lower a patient's heart rate using a swallowed propranolol pill, the dose had to be astronomically higher than the IV dose, just to ensure a tiny fraction survived that first circuit through the liver.
Yep, the liver was just chewing it up.
But wait, if doctors at the bedside clearly saw that the standard oral pills were failing, why didn't they just keep guessing and doubling the oral doses until it worked? Like, why did this require entirely new scientific studies to figure out?
Well, what's fascinating here is that trial and error with a human heart is lethal. You cannot just blindly double or triple a cardiac medication, hoping that this time enough slips past the liver.
Because if you guess wrong and the drug floods the system.
It stops the heart entirely. Exactly. You can't take that risk.
That makes sense.
So those bedside failures forced scientists, notably figures like Milo Gibaldi and Gerhard Levy, to step in and build a rigorous mathematical framework. They essentially birthed the science of pharmacokinetics.
So they didn't just observe the liver-destroying drugs. They built complex equations to calculate extraction ratios and exact bioavailability percentages.
Right. They gave clinicians a precise numerical language to predict that invisible confiscation process.
They essentially put a strict mathematical value on how much luggage the customs agent was going to steal.
Perfect way to say it. And once you can mathematically predict a biological process, you can manipulate it. Medical science stopped guessing and started intentionally hacking the checkpoint to save lives.
Let's look at how they do that, starting with what we could call hacking by route. The classic example in the notes is nitroglycerin, used for angina, which is severe, crushing chest pain.
Right, and nitroglycerin has an oral bioavailability close to 0. The liver destroys it completely on the first pass.
Which is obviously highly inconvenient for a patient currently experiencing an active heart attack. They don't have time for the drug to navigate the stomach, the portal vein, and the liver, only to be destroyed.
Precisely. And that is why doctors instruct angina patients to place the tiny nitroglycerin tablet under the tongue sublingually, or they prescribe a transdermal patch to stick on the chest.
Ah, so by absorbing the chemical directly into the superficial veins located in the tissue of the mouth or the skin, the drug completely dodges the stomach and the hepatic portal vein.
Exactly. It drains straight into the systemic circulation and hits the heart in seconds. It's an elegant physical bypass, but clinicians also engage in hacking by math.
Okay, and this is where things get incredibly dangerous if a healthcare provider doesn't respect the underlying biology. Let's look at that classic nursing trap involving morphine.
Oh, yes. Morphine undergoes a specific type of first-pass metabolism called extensive hepatic glucuronidation.
Okay, I saw that term in the notes, glucuronidation, and it sounds incredibly dense. What is physically happening to the morphine molecule there?
Well, inside the liver, there is a specific enzyme called UGT2B7. Think of this enzyme as a customs agent with a staple gun. As the morphine floats by in the portal vein, this enzyme physically staples a heavy, bulky sugar molecule, a glucuronide group, directly onto the morphine structure.
Oh, like slapping a massive, heavy luggage tag on a suitcase.
Exactly. And because that morphine molecule is now significantly heavier and bulkier, its physical shape has changed. It can no longer fit into the opioid receptors in the brain and spinal cord to relieve pain.
So the liver hasn't destroyed the morphine, but it has completely inactivated it.
Right. And because of this intense stapling process, the oral to IV conversion ratio for morphine is roughly 3 to 1. Oral morphine is mathematically 3 times less potent than IV morphine.
Meaning if a nurse is caring for a patient who is stable on 10 milligrams of IV morphine and the doctor says they are ready to go home on oral pills, the nurse cannot just hand them a 10 milligram pill.
No, if they do, that patient will be in severe agony within hours. The nurse has to drastically increase the oral dose up to 30 milligrams, specifically to feed the liver's stapling enzymes, ensuring that 10 milligrams survive to reach the brain.
Here's where it gets really interesting, though. I was reading the section on intentional drug design, and I have to ask about Suboxone. This goes back to the biological booby trap we mentioned at the start.
Yes, Suboxone. It's a medication prescribed for opioid addiction, and it's a combination pill. It contains buprenorphine, which stops the cravings, and naloxone, also known as Narcan, which is an aggressive antidote that instantly blocks opioids.
Right, so why would a pharmaceutical company put the cure and the antidote inside the exact same pill?
It is a brilliant piece of chemical engineering known as an abuse deterrent formulation. They literally weaponized first-pass metabolism.
How so?
While naloxone has almost zero oral bioavailability, the liver's enzymes absolutely shred it on the first pass. But buprenorphine survives a bit better when absorbed in the mouth.
Oh, I see. So if a patient takes the Suboxone tablet correctly, letting it dissolve under the tongue, the buprenorphine absorbs and works to relieve their cravings.
Exactly. And whatever tiny amount of the naloxone antidote they happen to swallow goes straight to the liver and is completely destroyed. The patient feels fine.
But if someone struggling with severe addiction tries to misuse the medication by crushing the tablet, dissolving it in water, and injecting it directly into a vein to get a high.
The trap snaps shut. By injecting it intravenously, they have bypassed the liver entirely. The naloxone antidote hits the brain completely intact, violently ripping the opioids off the receptors and plunging the user into immediate agonizing withdrawal.
Wow. So the drug companies literally rely on the liver's destructive power to make the pill safe to prescribe. It's incredible.
It really is.
But reading through the rest of the outline, this highly predictable mathematical system has some serious vulnerabilities. Like, if we can mathematically predict what the liver will confiscate, what happens if the customs agent gets distracted or overwhelmed or sick?
Chaos. Total biological chaos. And it often starts with something as simple as breakfast.
Ah, the grapefruit juice incident of 1989. This is easily one of my favorite accidental discoveries in clinical medicine.
It's such a great story.
So a Canadian researcher named David Bailey was running a routine study to see how alcohol interacted with a standard blood pressure medication called felidipine. Because it was a blinded study, he needed a way to completely mask the taste of the alcohol so the control group wouldn't know what they were drinking.
And anyone who has tried knows that pure alcohol is notoriously difficult to hide in a beverage.
Right, so he decides to use grapefruit juice, assuming it's just a strong, bitter, completely harmless flavor profile. He runs the study, draws the blood, and the results make absolutely no sense. The felidipine drug levels in the patients who drank the grapefruit juice had inexplicably skyrocketed to toxic levels.
Yeah, what Bailey accidentally discovered was that grapefruit juice contains specific chemical compounds that act as potent inhibitors of CYP3A4.
That's the metabolizing enzyme located in the wall of the small intestine we talked about earlier, right?
Exactly. The juice basically distracts and paralyzes the customs agents stationed in your gut. Because those enzymes are temporarily knocked out by the grapefruit juice, they can't break down the blood pressure medication as it passes through.
So suddenly, dangerously high amounts of the intact active drug just slip through the intestinal wall and into the bloodstream.
Yeah, and this is why today, if you take certain statins for high cholesterol or certain calcium channel blockers, the pharmacist will put a giant bright yellow warning sticker on the bottle telling you to avoid grapefruit juice.
Because if you drink it, you shut down your intestinal first-pass metabolism, which can lead to toxic overdose levels of the drug in your system.
Right, potentially causing severe muscle breakdown or kidney damage.
It is wild that a breakfast drink can hijack your pharmacology like that. But it's not just grapefruit, right? Alcohol itself is subject to first-pass metabolism, and the biology here is surprisingly sexist.
Yeah, it is. Most people assume this checkpoint only applies to complex prescription pharmaceuticals, but ethanol, beverage alcohol, is partially broken down in your stomach lining before it even has a chance to reach your bloodstream. This is handled by an enzyme called gastric alcohol dehydrogenase, or ADH.
In a landmark 1990 study published in the New England Journal of Medicine, proved that women naturally possess significantly lower levels of this gastric ADH activity than men.
Meaning that a woman's stomach lining is physically less capable of breaking down the alcohol on that initial first pass.
So if a woman and a man of the exact same body weight drink the exact same amount of alcohol in the same amount of time, the woman will actually absorb far more intact ethanol into her bloodstream.
Exactly. It is a fundamental biological difference in pre-systemic metabolism that directly dictates blood alcohol concentration.
Man, that is fascinating. I was looking at the mathematical models later in the notes, and the equations seem to suddenly break down when the doses of certain drugs get really high. It looks like the predictable percentages just stop working.
Look,
What is the saturable trap?
that is where nonlinear math catches even experienced clinicians off guard. For certain drugs, like the beta blocker propranolol, first-pass metabolism is not a flat, infinite percentage. The liver's enzymes can actually be saturated.
Like they just can't keep up.
Right. Think of a bouncer at a nightclub door. If 5 people try to rush the door, the bouncer can easily stop 4 of them, letting only 1 inside. But if 50 people suddenly rush the door at the exact same time, the bouncer is completely overwhelmed.
Oh, so he might still only stop 4 people, meaning 46 people suddenly burst into the club.
Exactly. If you double a dose of a drug with saturable metabolism, you don't just double the amount of drug in the blood, you overwhelm the liver's enzymes. The confiscation rate plummets, and a disproportionately massive surge of the drug escapes into systemic circulation.
Okay, speaking of overwhelming the liver, I have a question about a scenario that seems completely counterintuitive.
Okay, what is it?
If someone has severe liver disease, say advanced cirrhosis from years of alcohol abuse, their liver tissue is scarred and dying. Wouldn't that damaged liver struggle to process drugs, meaning the medication never gets activated, leaving them dangerously undertreated?
It's a very logical assumption, but it is actually the exact opposite for high first-pass drugs.
Really? How so?
Well, remember, for the vast majority of oral medications, the liver's job during the first pass is to destroy them, not activate them. If the liver is severely damaged by cirrhosis, it loses its ability to extract the drug. The customs agent is essentially asleep at the desk.
Oh, I see.
And furthermore, severe liver disease creates physical blockages. As the liver tissue hardens with scar tissue, blood pressure in the portal veins skyrockets. To relieve that pressure, the body literally builds new blood vessels, detour roads, to route the blood around the dying liver. This is called portosystemic shunting.
So the newly absorbed blood carrying the drug takes the detour and just skips the checkpoint entirely.
It never even sees an enzyme. So if a doctor absent-mindedly prescribes a standard oral dose of morphine or propranolol to a patient with severe cirrhosis, that drug completely bypasses the broken first-pass system.
Wow. So what is normally a safe everyday dose suddenly hits the brain with the force of an IV injection.
Exactly, causing a massive accidental overdose. This is why hepatic impairment requires drastic dose reductions for oral meds.
Because first-pass metabolism is so dynamic and clearly full of biological loopholes and detours, the sources point out that it's a massive breeding ground for dangerous medical assumptions. Let's do some rapid-fire myth-busting based on the nursing notes to clear those up. Myth number 1. A drug with a low oral bioavailability percentage is just a weak drug.
Completely false. Low oral bioavailability just means the oral route is a highly inefficient delivery method for that specific chemical structure. The drug itself might be incredibly powerful.
Right, like we discussed with naloxone. It gets shredded when swallowed.
Exactly. But if you inject a tiny amount intravenously, it is potent enough to rip heroin off a brain receptor and reverse a coma in seconds. The drug isn't weak, swallowing it is just a bad delivery strategy.
Makes total sense. Okay, myth number 2. Giving a drug via IV means it is safe from the liver forever. It completely avoids metabolism.
If we connect this to the bigger picture to understand why this is a myth, we have to distinguish between pharmacokinetics, which is what the body does to the drug, and pharmacodynamics, which is what the drug does to the body. Intravenous administration only skips the pre-systemic or first pass elimination.
Oh, so it just gets a free pass on the first lap.
Right. It hits the systemic blood, travels to the target tissue, and does its job. But the blood is constantly circulating. Eventually, that venous blood will carry the drug back around to the liver, and the liver will begin its normal systemic metabolism to clear the chemical from the body. 4V routing buys the drug immediate access. It doesn't grant it biological immortality.
Got it. And finally, myth number 3. Dose conversions between oral and IV forms are simple whole numbers. You just double it or have it in your head on the fly.
Absolutely not. As the morphine example showed with its complex stapling enzymes, conversion ratios are highly specific to the drug and rarely intuitive whole numbers. First-pass metabolism destroys a predictable but highly complex fraction of the oral dose. Relying on mental math instead of standardized conversion tables at the bedside is a critical patient safety risk.
So what does this all mean for you, the listener? Well, the next time you pick up a prescription at the pharmacy and see a bright yellow sticker warning you to avoid grapefruit juice, or the next time a doctor specifically instructs you to let a tablet dissolve under your tongue instead of swallowing it with a glass of water, you are interacting directly with your body's intricate first-pass metabolism.
You really are.
Yeah, you're navigating an unseen evolutionary checkpoint that is constantly shaping your everyday health. The route you take completely changes the dose you get. It is the unseen math shaping everyday health.
And as we wrap up, I want to leave you with one final provocative thought from the sources that hints at where this entire science is heading. We briefly mentioned earlier that the gut lumen, the physical space inside your intestines, is packed with bacteria, your microbiome.
Right, the trillions of microbes living inside us.
Well, we are now discovering that those bacteria possess their own metabolizing enzymes. They act almost like a pre-liver, dismantling drugs before they even reach the intestinal wall. And here's the profound part. Everyone's microbiome is completely unique, like a biological fingerprint.
And it changes rapidly, right? Based on your daily diet or stress, or if you recently took antibiotics that wiped out entire colonies of your gut flora.
Exactly. So if your personal, ever-changing gut bacteria are actively participating in first-pass metabolism, it means the confiscation rate is a moving target.
Oh, wow. So my dose might need to be different today than it was a year ago just because my gut flora changed.
Yes. It raises a massive question for the future of pharmacology. Could we be approaching a point where doctors can no longer just look at a patient's weight or liver health to prescribe a standard oral pill? Will they have to genetically sequence and map your specific gut microbiome on that specific day just to mathematically predict how much of the drug your personal bacteria are going to destroy?
We might have to rethink the entire concept of standardized oral dosing.
We just might.
That is a staggering thought. Your own personal bacterial colonies dictating whether your medication works or fails. We will leave you to mull that over on your own. Thank you so much for joining us on this deep dive into the unseen forces shaping our health, and we'll catch you next time.